Thank you, Shvila. I'm really happy to be here today. And I'll be talking about symptoms and challenges in patients with CTNNB1 syndrome. These are the topics that we will be covering today. All of the data that I will be presenting was gathered as a part of a research that our team has been working on for the past 2.5 years. So I will talk briefly about our research in the beginning of my talk, and later we'll move on to the most common symptoms. Our research is focused on genotype-phenotype correlations in patients with a CTNNB1 mutation. As you can see, we started enrolling patients in March of 2021, and our last interview was in June of 2022. So in over a year, we were looking to enroll anybody and everybody with the genetically proven CTNNB1 mutation, regardless of their age or their country of origin. Parents were first asked to fill in a pre-meeting survey and to send us important information on their child's medical status, such as their genetic information, various scans and pictures. And later they were invited to meet me online, where I took them through a structured interview, which consisted of over 500 questions. Basically, our topics of interest were diverse. We were asking about family history, physical appearance, prenatal, perinatal, and postnatal risk factors, as well as developmental milestones, and basically all areas of development, motor function, speech function, eating and drinking, sleeping, and so on. These are all of the standardized diagnostic tests that we used in our interview. I will be covering the most important ones during this speech because I only have 15 minutes, so I can't keep going on forever. I interviewed 124 patients in total. 43.5% were female and 56.5% were male. On average, they were 70 months of age. The youngest boy who participated was 7 months old, and the oldest young girl was 21 years old. They were residents of 20 different countries. Most of them came from the United States, China, and Spain, but we had quite a good participation all around the globe. We noticed basically typical dysmorphic features in these patients. The most common one was a broad nasal tip, followed by long and or flat philtrum, esotropia, small alenasi, big ears, a thin upper lip, microencephaly, and thin hair. And these features were not only present in Urban, but in other children as well. As you can see here, all of these children have a broad nasal tip, long philtrum, thin upper lip, and esotropia, regardless of their gender, age, or nationality. Next, we asked about developmental delay. For the purpose of this talk, I decided to focus on 4 milestones only, but we asked about more. Based on our data, patients with CTNNB1 syndrome started rolling from their back to their tummy at a mean age of 8 months, while usually we would expect them to be able to do so by the age of 6 months. 1.6% of the children had not yet reached that milestone by the time of our interview. Patients with CTNNB1 syndrome started sitting without support at the mean age of 14 months, and 22.6% of children had not yet reached that milestone. Usually we would expect children to be able to sit independently by 8 months of age. With walking with support, we noticed that patients started walking with support or cruising by the mean age of 25 months. Usually we would expect them to do so by 12 months, and almost 17% of children had not yet reached that milestone. And this percentage was even higher when we were discussing walking independently. Usually children start walking completely independently by 13 months of age, and with those who were able to walk independently with CTNNB1 syndrome, the mean age of reaching that milestone was 39 months. As we can see, all of this data points to a significant developmental delay, and as children get older, the disparities between healthy children and children with CTNNB1 syndrome just grow bigger. We used the gross motor function classification system to score their motor function. Basically what this classification system does is classifies children into 5 levels depending on their motor function, and it is validated for children of different ages and in different stages of development as well. Level 1 describes a child who is able to walk independently on even and uneven terrains, to walk up and down the stairs, jump and run, And in younger children, it describes a child who's able to sit independently while using both hands to manipulate objects. 16% of children corresponded to level number 1. In level number 2, children are able to walk independently but require some assistance when walking on uneven terrains or when walking up and down the stairs. And in younger children, it describes a child who's able to sit but has to use their hands to support themselves for balance. Almost 40% of children, so the majority, corresponded to being level number 2. In level number 3, patients are able to walk with a handheld mobility device or with some sort of a support and are transported for longer distances or on uneven terrains. In younger children, this describes a child who's able to sit only when their lower back is supported. 30% of children corresponded to being level number 3 on this scale. In level number 4, patients are able to walk with a handheld mobility device but are usually transported. And in younger children, this level describes a child who can only sit when their full back is supported. So almost 11% of children corresponded to being level number 4. In level number 5, patients are unable to walk. They have to be transported at all times. And in younger children, this describes a child who is unable to maintain anti-gravity postures in their neck or their trunk. And 3.3% of children corresponded to this level. As I said before, 56.4% were unable to walk independently, and this percentage was even higher when we assessed using a wheeled mobility device to be transported for longer distances. 72% of children had to depend on some sort of a wheeled mobility, be it a pram or a power wheelchair or a manual wheelchair. The most common motor symptoms were central hypotonia and peripheral hypertonia, which we expected, and we also found high numbers in ataxia, dystonia, and muscle spasticity. We assessed their visual function as well using the visual function classification system, which again uses 5 levels to describe different visual abilities. Level 1 is normal vision and level 5 is complete blindness. Most of the children corresponded to level number 3, which means that they're able to use their visual function but require some adaptations, for example, the use of glasses. The most common visual impairments we encountered were esotropia and farsightedness, with some reports of nearsightedness, nystagmus, and retinal detachment as well. And based on our data, 8% of children had fever, which was wonderfully explained in one of the previous talks. We assessed their speech function using the Viking speech scale, which uses 4 levels and is validated for children aged 4 years or above. Level 1 describes a normal speech development. Almost 3% of children corresponded to level 1. In level 2, speech is imprecise but usually understandable to unfamiliar listeners, and we found that 28.6% of children corresponded to this level. In level 3, speech is so imprecise that unfamiliar listeners usually do not understand it. Most of the children, so 40%, corresponded to this level. And in level 4, there is no understandable speech. 28.6% of children were level 4. Keep in mind that this number is only for children aged 4 years and above. If we count in the younger children as well, 41% of all of them were unable to speak. We assessed their eating and drinking ability, which again uses 5 levels. Most of the children were level 1 or level 2, which means that they can eat and drink safely with some limitations in level 2, meaning that some of these children took a longer time to finish their meal as their peers, for example. Only 1.1% of the children were level 5, which means that they have to be fed through a tube. We assessed psychopathological symptoms. Interestingly enough, most of the children had not yet been formally assessed before our interview, and out of those who have been, almost 47% were found to have autism spectrum disorder, and almost 80% were found to have intellectual disability. Based on our data, 50% of patients have autism spectrum disorder, 52% have a mild intellectual disability, and 27% have a moderate intellectual disability. We also found higher rates of autoaggression and hypersensitivity to outside stimuli, such as sudden voices, sudden sounds, or sudden touching. Parents also reported increased rates of withdrawn behavior, symptoms of anxiety and depression, attention problems, thought problems, and obsessive compulsive behavior. Approximately 60% of the children attended school or kindergarten, and most of them, over 94%, required some sort of additional help in school, while 60% already went to some sort of special education type of place. Last but not least, we assessed sleep problems. 45% of parents reported no problems at all, and the other ones reported small or serious problems. Most of the children from these two categories were taking some sort of a sleeping medication, and the most common problem the parents were pointing out were frequent awakenings with trouble falling back asleep. This concludes my presentation of the most common symptoms. We're still analyzing our data and are in the process of writing and hopefully publishing an article on the topic, so stay tuned for more detailed information about the subject. Thank you to all of the parents who participated in our study, and thank you for your attention.